So Cecil Whitley said the surgeon can do more for the community by operating on urgent cases and saying that recurrence rate is low than actually by operating on cancer case. So hernia is very important because it's one of the most common surgeries done in the world. So in ventral hernia, we have almost about 5 million laparotomies being performed all over the year, and about 400,000 incisional hernias that develop. And it's quite a challenge to treat because there's a multifactorial reason why they form. It's not only the technique, but also sometimes abdominal normal collagen metabolism that plays a role in this. So why we need to fix this? Because it can lead to complications such as obstruction, incarceration, strangulation, and can cause fistula, back pain, and then loss of abdominal function and also like back pain. So the aim of the repair is actually to restore the abdominal wall continuity. And now, most importantly, we feel that we should restore the linea alba, and that is helps to help the functional part of the body, especially for back pain, and to have as less tension as possible. It's not possible to have no tension because in abdomen, as soon as you repair, the patient coughs and comes out of anesthesia, they will develop some tension. But the issues that we have is that we don't have a single method, universal technique for repair. There are many ways that we can repair this. And of course, we know now that primary suturing has got a high risk of recurrence. Um, but we have to now decide whether if it's extremely small, less than 1 centimeter, we can do primary repair. But otherwise, we have to decide what kind of repair we're going to do, whether open, laparoscopic, endoscopic, whether where we're going to place the mesh, whether it's onlay, sublay, inlay, and whether we need to add a component separation. And if you do component separation, whether we have to do anterior component separation or posterior component separation. And nowadays, of course, we also do robotic, which I'll do. And if you have loss of domain, then what are the techniques that we can do? So we have evolved from doing open to iPhone Plus to ETAP to TAPE, and now we do R and robotic, all trying to decrease the recurrence rate and improving the function. Of course, we don't close just the bridging the gap anymore because this can lead to a pseudo hernia, and usually in iPhone Plus we recommend to repair the defect and then put the mesh. So of course iPhone Plus now has got lower recurrence rate compared to just the iPhone, and it can be done up to 8 centimeter defect. Of course, larger than this usually will require component separation. Also, sometimes when we have a ventral hernia, we can do, and it's associated with diastasis, then we have to repair the diastasis along with the hernia, because if not, then the recurrence rate is also high, you can get a pseudo hernia. And uh, we can do this endoscopically in a subcutaneous method. So we can just put the 3 ports in the along the suprapubic line, and then we create a plane between the rectus sheath as well as the subcutaneous muscle. And then we can go all the way up to the zipisternum on either side. And in this way, you can repair the diastasis along with the hernia. And this is a simple technique uh, and good results that we can do. And if the hernia is small, we can primarily repair it, and then we can use like a double plication method to close the diastasis. Some surgeons, of course, will put a mesh here, but usually I recommend not to put a mesh because otherwise it can give rise to seroma and persistent seroma or infection. So with a double plication technique, we can get good results, but it's provided that the hernia is small. So usually I decide this method. If the hernia is small but the diastasis is large, then I use this technique. If the hernia is large and the diastasis is small, then we can do the other techniques like the ETAP TAR or um, the iPhone Plus repair. So this one we go all the way up, and then now you see the umbilical hernia here, and then we detach the hernia. And then we continue to go all the way up to the sternum. And now we mark the diastasis. And the umbilical hernia is right in the center. And then we will repair the umbilical hernia primarily. But if you want in this area, you can also put a mesh in the preperitoneal plane and then close it up. And then we use a non-absorbable V-lock to suture the diastasis. So this can be done laparoscopically, and even robotically is even easier. Diastasis can also be repaired intra-abdominally, but here you get a better visualization, and you can actually get the sheet approximated quite well. So after this, I will use another layer, maybe either intermittent stitches or even another continuous layer, and we call this double plication. And when we come very close to the port, you can actually just extend the port a little bit and then even close the last part below the suprapubic line. So this is the second layer. And then we make sure that we mark the umbilicus so we know the exact area, and we can then reconstruct the umbilicus. And now we'll bring the umbilicus. And then we can leave a drain through one of the ports. So this can be done robotically, and our robot allows better dexterity that you can apply MIS techniques for more complex, and you can actually close more than 95% of the defects, and it makes component separation much easier. It is feasible, and you can look at the results on multi-center evaluation, and when they compared open versus robotic, it was shorter in terms of hospital stay, of course, longer in terms of operative time, but over once you get past the learning curve, then this can be also, you can get over this. So when we compare open, laparoscopic, and robotic, of course, lab and robot is better than open. In between lab and robot, there's not much difference. Again, the operative time is a bit more, but the suturing technique is much easier in a robot. So even if you look at the IHS guidelines, the RIPOM, the results have similar rates to laparoscopic rate, but better than open repair, level 2C evidence. And this may be considered comparable to laparoscopic ventral hernia repair. So what about component separation? Usually if the hernia is very large and we are not able to bring the fascia close together comfortably, then we may need to apply a component separation. So this was first described by Young, made famous by Ramirez, where there are various components of the abdominal wall which we can actually separate. So if you look here, there is one area with a posterior rectus sheath, and this can be, you can separate this. You can also separate the anterior sheath, which is on the external oblique, or you can separate the transversus abdominis muscle. So if you do this anteriorly, then we have anterior component separation. If you do transversus abdominis, then it's a TAR or posterior component separation. Of course, we do not do both the techniques at the same time because it will lead to abdominal dehiscence. So we have to choose either anterior or posterior. So we can get about 4 to 8 centimeters defects that can bring together in a manner to close the defects. This was initially done in the open method, but what they found was that all the lateral perforators were destroyed, and this led to an increase in the midline dehiscence and wound infection. So the MD Anderson method, where we create a small tunnel up and down, and then we call perforator preserving anterior component separation, where you can see here the perforators are preserved. So this can be done, and the technique is, of course, we open the subcutaneous plane up to the area of the external oblique, and then 2 centimeters lateral to the uh, external oblique, we aponeurosis, we make a cut, and we expose the muscle. So this is done in an open method, and of course nowadays we do this laparoscopically in a very similar manner. So the where we place the port, we place it outside of the rectus sheath, and we go just below the external oblique fascia, and there we can introduce the balloon, the same balloon that you use for the TEP technique, and then you can inflate that balloon, and then you space, and then uh, so here is what we put, and then after that we put one port, and then sometimes we can put a second port to do that. You can either put a port up below the subcostal margin or even below above the inguinal crease, depending on your comfort level. And then we use a hook to dissect and cut off the external oblique aponeurosis just about 2 centimeters lateral to the linea semicularis until we see the subcutaneous pressure. So this is very useful because it has much shorter hospital stay, less pain, and significant lower wound infection rate. Also, the advantage that if you have a stoma, then also you can do it because you're in a different plane from that, and actually you can do the component separation without having to expose the stoma. So again, this is a tiny video. So we go between the external and internal oblique space, just like how you're going to create the ETAP space, but you're not in the rectus sheath. This is lateral to the rectus sheath. And then we open the balloon up, and below you can see here is the internal oblique, and above is the external oblique. So here is the external oblique, and below is the internal oblique. And now laterally, we will insert a 5 mm port. And then we open the space, we go all the way down until the inguinal ligament. And then we use your other hand to press from the outside so we can get orientation that you cut along the same line. So when you cut here, then you can see the subcutaneous fat, and then use your hand externally to guide as we are going up. Sometimes we may need to add an extra port to help us to go all the way up. And then we do similarly on the other side. And now I go intra-abdominally. And then you can see the hernia here. It's like multiple Swiss cheese defect. And we do the adhesiolysis. And once the adhesiolysis is done, then we will suture close. Again, I use a non-absorbable V-lock. This is quite challenging laparoscopically, but actually through robot is much more simpler. So sometimes we just bring it half after 2-3 stitches, then we put together, and then we use a second layer to stitch. Or actually you can even use intermittent stitches by using a Rhoda's knot. And then of course we place a composite mesh, and then I fix it with an absorbable tacker. And then we use a anti-adhesion, extra anti-adhesion barrier. But actually composite mesh already has a anti-adhesion barrier, but in Singapore we call it kiasu, means extra careful. So, what are the issues with anterior component? Again, it's slightly technically challenging, and it is not perforator sparing, then the increased wound distance, and we need to put intra-abdominal mesh. And of course, sometimes we also need your mesh to cover the area of the component separation. Otherwise, they can develop a pseudo hernia in that area. And the recurrence rates are slightly higher. So this Yuri Novitsky came up with a technique for transverse abdominis muscle release, or TAR. And this is a posterior component separation where we separate the transverse abdominis muscle from the internal oblique muscle. And in this way, actually, you can get some space, and you can get actually a good amount of space. It is important here to uh, mobilize the rectus sheath properly, and most important is to preserve the neurovascular bundle. So we need to be familiar with the three spaces. We have the pre-peritoneal space, we have the retrorectus space, and we have the pre-transversalis space. So we need to bring this all into one space by dissection. And the easiest way is actually in the lower part of the abdomen where there is no transverse fascia, and you can just directly go into the pre-peritoneal space, and then we can start from here. And then when you come up, you will first face the membranous part, or the fascial part, which is easy to cut. And then in the upper part, you will see the muscular part, which we need to separate. So it's very, very important to preserve the neurovascular bundle and not go into the wrong plane. So the also we must remember that the transverse abdominis muscle is not linear, but it is curved. So it curves this way. So it's not in a straight line. You just need to follow it in a curve, and we can better see this during the video. So uh, now that we have shifted more towards defect closure, then this is one of a good method to strengthen the abdominal wall. So this is how we do it. So I do what is called, so there's two ways in which you can do either the ETAP TAR, or you can do the TAPP TAR. So I prefer the TAPP TAR, and this TAPP TAR because then you have better visualization. So we just start a few centimeters uh, past the rectus sheath, and we open up this space, and you can see the rectus muscle here. And the advantage of TMPP TAR is that if there are dense adhesions, then you can do adhesiolysis before, and at a lower risk of injury to bowel structures compared to the ETAP TAR. So once you open this sheet, then we just go along this in a line, and we open it up until we see the neurovascular bundle. So this is the upper part. However, when you start, I recommend to start from the lower part because it's easier. And now you can see the linea sabulinaris, and then you will see the neurovascular bundle here. So if you cut this, it's a disaster. So just 1 centimeter before we make a cut, and you will see the transverse abdominis muscle, and then slowly you can use the hook to release it. And it's important not to go superior to it, but to go below it. Because if you go superior to it, then you are in a plane between the transverse abdominis muscle and the internal oblique, and you shouldn't be in that plane. You should be in the pre-peritoneal plane. So we just release that upper part, and then you come back into the peritoneal plane. So here is released, and then we develop the plane below this muscle here. Then we start in the lower area, and this is a very familiar because everybody does TB inguinal hernia, and then you can open that all the way laterally to the lumbar fascia. And then lower part here, you can see the pubic bone, and then we connect it upwards. We'll see the fascial part. Again, a bit of the muscle fibers we release, and now we will do the similar on the opposite side. So we go down and connect. Again, you can see the neurovascular bundle, and we will preserve this. And whenever we see the muscle, we'll release it. And now we have the plane between in the preperitoneal space. We have made everything into one. And now we will actually repair the superior part first. So again, the advantage here is actually you have a lot of space as compared to the ETAP TAR, the TMPP TAR, we got more space to do this. And then we close this. And sometimes we put some transfascial sutures, and then now we close the posterior sheath. And then we will place the mesh. Sometimes we already, once we do one side, we can place the mesh in and tuck it on one side and keep it. So you can save some time. And this is the after closure. And then we measure the defect and we put in the mesh. And here, because this is not in the peritoneum, we can put a simple mesh. It does not need to be a complex mesh, composite. And then we can fix at the Cooper's ligament. And then sometimes I will put the glue, the tissue glue. And then we can leave a drain also in this area. So now this can be done robotically, and this is much easier because with a robot, the instruments are very dexterous. And again, here we reduce the hernia. This again a T8 part, and then this is the inguinal area, which are very familiar. And then we go from bottom up technique. So as I said, it's much easier because from this space, you will see the membranous part, and you can cut this easily. And you can see this is the fibrous area. And then now you will come to the muscle. So you can keep on cutting the fibrous area, and you check always posteriorly to see if the muscle is there. Here we go all the way side to the lumbar fascia. Now you start seeing the muscle here, and then you can do the transversus release. This is the bottom up technique. And I think when we start off, this is always a good technique because you can see the fibrous part easily, and there you can see the muscle, and we are below this space. We roll the mesh and we place it there. And then we do on the other side. And then we will close the defect. And the robot advantage is that the image can be inverted. And then actually, when you're suturing, it looks like it's from below top suturing. So this is a very nice part of it because the suturing is very comfortable to sit and suture. And then we roll the mesh over, and then either we can put a glue or sometimes you can just put some fascial stitches. So when do we use TAR? Usually more than 8 centimeter defect, loss of domain, and then a narrow rectus space which is less than 5 centimeter. And we find that if you are having tension on the posterior layer while doing a reef stop up, then we can add on the component separation TAR. So this is an important arm in the management of complex hernias, and robot has made it easier to actually do it. Even some otherwise we would have done it open, then those can be done using the robot, and it's quite easy. But at some point we have to say maybe this cannot be done in a laparoscopic or robotic, And these are when there are extremely large defect with significant intra-abdominal lesions or loss of domain or erosions and other complex situation. And in those cases, then we have to do this open. So loss of domain, we don't have a standard definition for it, but it's a situation where most of the abdominal contents are out of the hernia sac, either while standing up or lying down. And some examples are like this, and it's a challenge always to do the surgery. I will move forward because you're all experts in terms of operative planning. It's important if the patient is obese to make him lose weight first before doing the surgery. And if they are smokers, then they should stop smoking. So what do we do if we have significant loss of domain? There are some techniques that we can do. One is what is called as a preoperative progressive pneumoperitoneum. This one is good for uh, actually, for me, the indication is more for extremely large inguinal-scrotal hernias and not more that much for ventral hernia. Because what we found that while we do this, when we do this peritoneum, even the hernia sac also increases in size. So sometimes this is a challenge, but a way to judge this is using the hernia sac volume with the abdominal cavity volume and use the volume ratio of this. If it is more than 25%, then it's an indication for PPP. We use like a catheter to put, and then daily we fill in about 100 ml of gas until we reach the volume. But honestly, I just done a few, but I don't like this technique because when we're doing, especially for ventral hernia, even the hernia sac expands, and I don't find it useful. I think it's more useful for extremely large inguinal-scrotal swelling because that's where you're going to bring back all into the abdomen, and you need the abdomen to be a bit more pliable. So a better technique now that we use is the Botox injection, and this has shown to loosen the abdominal wall that you can get actually more cover. So how do we do the Botox technique? Is basically we use 50 mils of the Botox in each of these. So usually I would use 150 mils on each side. So total is 300 and 50 mils into each muscle. So using ultrasound, I use the help of our intervention radiologists and ultrasound guided. We use inject 50 mils into the external oblique and then 50 mils internal and then 50 mils transversus along this line, and then similar on the other side. Usually we will wait for about 4 weeks to before we do the surgery because then you can get a good so-called expansion. So here we see we use an ultrasound guided and we inject into each layer external oblique, internal oblique, and then transversus abdominis. So the other technique that we have, and this is very, very good and very easy technique called the peritoneal flap hernioplasty that was started by Andrew Jabot, where we preserve the hernia sac while we dissect it. So we don't excise it, but you preserve the sac and then you use that as a double breast to form a layer. So you get good thick cover in case you have very large defect that you cannot close. So this is a very useful as a backup option. And later I show you a case where that can be used. Of course, these are some traditional methods like single excision, Whitman's pads, a Velcro material. But this one we use mostly in trauma when the abdomen is left open. Then daily we can actually close it. So of course, tissue expanders are also available to do this. And you can use autodermal grafts to do, for example, like this. We can cut it up and then put an autodermal graft, and then you can get something like this. So um, you can also use flaps from different areas, rectus, latissimus dorsi, external oblique, etc. And free tissue transfer is also possible. So, for example, like this gentleman, unfortunately, he had colonic polyp that underwent had a perforation and then had a laparoscopic converted to open, and then he had leakage, bleeding, relook laparotomy, multiple relook laparotomies, and then he had basically uh, uh, hernia repair in the preperitoneal space where they put a mesh and the mesh was eroding like this, forming a fistula. So this, of course, is something that maybe we cannot do laparoscopic or robotic. So we had to do this open technique. And this was his CT scan. And what we did was initially we tried with the PPP, but it didn't work very well, and he developed a slight pneumothorax. So we had to abandon it, and we used Botox. And Botox, we injected it, and then after 4 weeks, then we did the surgery. So this was the initial, and then we opened the subcutaneous plane, and here we're doing the open component separation. So you can see the perforators there. You can see the perforators here. And we open this space. And then we have preserved the peritoneal flap. And then we put in the preperitoneal space, we put the mesh. And then we use this. You can see the entire set. We still preserve it. And we use it like a double-breasted technique to close over. And you can see it's very thick. So actually it forms like one entire muscle area, and then we have to close it primarily leaving drain. So in conclusion, functional restoration should be the standard approach. All ventral hernia consider reinforcement with a prosthetic mesh, and minimal access techniques will decrease the pain and improve outcome. Loss of domain is a challenging situation, and ventral hernia should be customized to each patient, and a tailor-made approach is necessary. Thank you very much.
Comprehensive and very detailed. Now we are open discussion. Any question or comment from the floor?
Thank you for your excellent presentation. You have a comprehensive review and also your personal experience, especially in the endoscopic part and hernia approach. I have a question. Recently, I reviewed the paper. It has a meta-analysis of the comparison of the ETEP and iPhone, including iPhone Plus, including component top in the ETE technique, and found that the ETE is better than iPhone in the hospital stay shorter, and the pain 1 week stay would take less, but the recurrence and the surgical side occurrence is the similar. How you think about this meta-analysis, including 12 paper, 4 randomized study and 8 cohort study. Do you think this conclusion is reasonable or not?
Very good question. So I think the meta-analysis paper, there are some bias in the paper, because one is that when they look at the ETP, it's done by an expert group of surgeons, and then number two is that they compared all together with the iPhone and the iPhone Plus. So we know that the iPhone, of course, has got not as good results as the iPhone Plus. So these are the situation. So in terms of ETAP, is a very good technique, but it is quite technically challenging. So the learning curve is steep. But once you learn that, then it is good. But the complications from that also can be quite severe. especially the crossover. So the third thing in the meta-analysis is that when you look at the size of the hernia defect, you will see that a lot of the ETAP TAR, the hernia actually don't need the TAR. So they are 4 centimeter defect, 5 centimeter defect, and this defect actually can be just closed primarily and with a mesh, and it does not need to have a TAR. So with of course smaller hernias, the TR results will be better. So nevertheless, I think there is always the ETAP TAR is a technique to stay. So in personally, I prefer the TAPP TAR because we can see the space much better and we can avoid injury to, because in case of very complex hernias, when you get pushed in the ETAP space, you can't see the adhesion and then there's a risk of bowel injury and things is higher. Yeah. So,
Thank you, thank you. Yes, but I think in the ETP, they have a choice bias. Most ETP is the primary ventral hernia or midline hernia. And in our daily practice, we have much more incisional hernia, recurrent incisional than the primary ventral hernia. So the selection have a selection bias. So ETP in the past less than 20 years, most surgeons select the easier to do is the easier one to
yes. Also, the IPOM, the trials, when they look at the papers, a lot of the studies, especially maybe like say Asia, Middle East, for IPOM, they did not use a composite mesh, and they used primary like a polypropylene or polyester mesh without any adhesion barrier. So their rate of bowel adhesion and erosion and complication is higher. In our own hospital, in my last hospital, Tan Tock Seng, we did our 10-year study on ICOM Plus. We look at the result, and the mesh-related complication is very low. From 5,000 cases, only 3 mesh-related complications, and that also is because maybe inadvertent bowel injury during the dissection that caused rather than it developed as a sequelae. So with the new measures, like I think Ventrolite by Bard or the Simutex by Medtronic, these are actually quite safe measures. There are some grade 1 adhesion, but many times when we go back to repair other operations, we find it's actually well integrated with minimal adhesion. So, but I think both are good techniques. We must choose depending on the patient and tailor-made into the patient. If it's a very small upper little hernia, maybe just open primary repair is good. If it is, a small hernia but large diastasis, maybe endoscopic scola is good. If it's a large hernia, small diastasis, then an IPOM repair. So complex cases, we design, we use ETAP TAR. So I think we have to tailor-made this surgery for the patient.
Yes, thank you.
Dr. Ross, thank you for your excellent speech. I have 2 questions for you. The first one, in the case of diastasis rating, will you put the mesh? Because I found you don't put the mesh in repeating. And based on this, will you perform the sublamination treatment for the dialysis rating? And my second question is, you emphasize the double layer suture. Could you provide us some tips some tips for this technique? Because we always try to suture it for 1 layer, but then your technique, I think, is very good for us.
Yeah.
Thank you.
So for diastasis, as I mentioned, I used to put the mesh. I used to put before maybe onlay mesh, but we've had one situation where there was a persistent seroma for long. And actually, then I was operating with a very old plastic surgeon from Brazil. I think you probably know about Dr. Marcos. And he showed me his series where he done primary repair for double plication, and his results are very good. And so I slowly started using the double plication and not putting the mesh, and the results actually is quite good. So usually if the hernia is small, then because after you repair the hernia also the rectus sheath will close over it in a double technique. So even actually 2-3 centimeter hernia, we can get away without the mesh. So usually for easy endoscopic suturing, I use the V-lock number O non-absorbable, 45 centimeter length. So it's a bit chilly, but you can use that. And then above that, I use again a second layer of that. Or sometimes I will just use intermittent stitches using the extracorporeal knot, like a Rhoda's knot in between. So yeah.
As you mentioned, the Botox and PPP, how do you think what's different between this method and the component separation in the complex abdominal wall?
Yeah, okay, excellent question. So I think the Botox can help to reduce the number of component separation. So if you feel that the patient is borderline and maybe that this one requires component separation, then it's good to do a TAR. So when we do the CT scan, then we can see the gap between the hernia, and we measure the from the lumbar fascia to the rectus sheath the distance, and then after we give the Botox injection, after 4 weeks, we'll repeat a CT scan. Then we can see that we have got some extra length. So then we try with the laparoscope to see whether we can close it with minimal tension. Of course, if we can't close it, then we have to still do the TAR. So one of the studies done actually has shown that they have reduced the number of TAR by 15 to 20% by doing the preoperative Botox. For PDD, as I said, the problem is that when you inject the air, even the hernia sac keeps expanding. So there's not much benefit of PPP. So we have stopped doing the PPP.
Good question.
Yes, thank you for the wonderful speech. I'm curious, because we know that obesity is a key factor to related to the poor outcome and the complex visual repair. According to your experience, when would you suggest patients to do like even the bariatric surgery before the visual repair? What kind of has the color value for the BMI?
Yes. So another excellent question. 2 weeks ago, I actually talked about obesity and hernia in the obesity meeting in Mumbai. So, so actually, this is a very, very complex situation because we have to use the algorithm. First, we have to decide if the patient has a patient come to you for hernia repair, or is he come for obesity treatment? That's the first algorithm. Because if the patient has come for hernia repair and he has no idea about obesity or obesity surgery, then we find very difficult to convince this patient that I come pain, hernia is regulating, what we want to do bariatric surgery. So it's very difficult to convince this patient. So we emphasize that the patient should have some preoperative weight loss. So usually for us, maybe 15% of the weight loss is good enough. In terms of BMI, I think if it's morbid obese, maybe we don't actually, in the study, there's no cutoff on the BMI. But usually more than 40 BMI it will make the hernia surgery quite challenging. And the reports have shown the studies that the more the BMI, more the complication. So of course, if it's borderline 30, 32, 35, we can still do the hernia repair. But in that case, also in obesity, laparoscopic or robotic has shown to have more benefit, and the studies that have done show that there's good results, and that this can be done. The hernia repair can be done safely, with less wound infection and less recurrence rate. Now, the second issue is that if there's a hernia and you're planning the bariatric surgery, then whether we repair it at the same time or at a different time. So if usually nowadays we can repair it at the same time, and we can actually use the mesh also, because the studies have shown that and for sleep, no problem at all. Bypass, you have to be careful and make sure that there's no extra spillage. So they can still use the mesh so long as there's no colonic perforation or things like that. But there's a few ways that we in Singapore also we have a problem, because after bariatric surgery, they have a lot of weight loss, and then they undergo abdominoplasty, and abdominoplasty is not covered by insurance. So sometimes if the hernia is not significant, we will do the bariatric surgery, and then we wait for the weight loss. Once they have the weight loss, then we do the hernia as a complex hernia and use abdominoplasty under the complex hernia repair, so that we can get insurance coverage. But the studies have shown that if you reduce the hernia and it's reducible and you don't repair it, then the the risk of strangulation, obstruction is quite high. So if you have a hernia, then it's better to repair it, at the same time. So sometimes I discuss with the patient, if it's a small hernia, then maybe we just primarily repair. But I tell the patient there's a high risk of recurrence. But if it does occur in the next 1 to 2 years, by then you have the weight loss, then we do the hernia and the abdominoplasty at the same time.
May I ask you what's the criteria for removal? Because I encounter I removed it maybe 2 days after the operation, but the patient suffers suffer from seroma again. So do you have the experience to keep the drain with the patient at the same time, or and come back to remove them in the outpatient?
Yes, so that's what we can do. But there's one technique that I do, and I didn't show in the video. But this is a technique that we do is, so once we once we have prepared the diastasis, then from anteriorly on either side, we take I take Vicryl or PDS and from subcutaneous to the fascia, and I close it about 3 sutures as we are closing. So that closes the gap and decreases the seroma, radically. So then the seroma rates are very low, and then usually we wait for actually less than 10 minutes per day before we remove the drain. But after doing this technique, it has become much less the rate of seroma. So sometimes we even put the tissue glue in there. Any question?
No question.